If you want to go, raise your hands.
All right, I'll give it a try.
All right, go ahead, James.
66-year-old female is complaining of epigastric pain, nausea, vomiting, and fatigue. After performing a 12-lead ECG, what is your field diagnosis? Is this patient having a STEMI? Which coronary artery is involved? All right. So I'm going to look at this one and I'm going to see, I see more depression. I already see some depressions in V1, V2, because actually the arrow's there.
Yeah.
You also see a lot of depressions on the 2-lead. That 6-second strip of the 2-lead, you see some depressions right there. So you already know that this patient is ischemic. So it's going to be it's definitely a STEMI. But
where do you see elevations? Do you see elevations or you don't?
I see elevations in 4, 5, and 6.
4, 5, and 6. So these, let me do. Let me do the. So here, if I draw the line on the isoelectric line, these are not per se elevations, right? They're not elevated. But let me point you to this here.
3 and AVF.
Right? So here, if you look closely, right, you actually have elevations in which leads?
AVF.
Yeah, lead 3, this is lead 3, and this is AVF, right?
Oh, I didn't see the numbers on the side, so I thought that whole strip was AVF.
Yeah. So all the 12 leads are standard, right? So if you go from this side, so this will always be 1, 2, 3. This is always going to be AVR, AVL, AVF. This is always going to be V1, V2, V3. This is always going to be V4, V5, V6, unless you do a 15 lead EKG where you relabel them. Otherwise, this is standard, right?
All right. So now that I see it, there's elevations in 2, 3, and AVF, but there's in those, but you also have depressions, like I said, in the 2-lead at the bottom, the 6-second 2-lead, and you also have depressions in V1 and V2.
Yes.
So I'm gonna say that the LAD is included and with this strip.
So when we say LAD is included, we basically signify the artery that's infarcted, basically the artery that has a STEMI. So based on this, where the elevation is occurring, right, the elevation is actually at right coronary artery. Because if you look lead 2, 3, and AVF, right, if you're going to say there's elevations here, this corresponds to RCA. But these are reciprocal changes, right? So reciprocal changes means the opposite view, and they're depressed. So this doesn't signify for now that there's any lesion in the LAD. So this person right now that we can see clear-cut ST segment elevation is 2, 3 AVF, or you could say 3 AVF. That's inferior wall, and we see depressions in V1, V2, which I agree with you, right? So what is the big concern here? What do we need to do?
We definitely need to call telemetry and get approval to go to a cath lab.
Yeah, but is there any other EKG you want to perform? Because we have inferior wall, right? This is inferior wall.
I mean, honestly, I would move V4 over.
Exactly.
I would move V4. I would move V4 over.
Exactly.
And probably move the 7 and 8.
Exactly.
I mean, 8 and 9. Apologies.
So we're gonna do 15 lead EKG. Why? Because we gotta see, right? We gotta see if there is right ventricular involvement, right? And if there is posterior involvement. Here, I don't think they did V4R. So they did not do V4R. They only did V8 and V9, right? So they basically look at the posterior wall. And if you look here, right, you only need 0.5 millimeters elevations. And here you have it, right? You have 0.5 millimeters elevations. Here it's not prominent, but you could see, right? It's a little.
You can see it right there. When you just put that line at, you could definitely see it right there.
Yeah, the V9 is definitely there. So we know that this person is having a lesion that's posterior wall. And how we know this? There were elevations in 2-3 AVF, so inferior wall, plus there were depressions in these leads, which can signify posterior wall involvement. And they did the 15 lead EKG, and they definitely see, right, that it was a V8 and V9 involved. So this person has inferior wall MI, and it has posterior wall infarction as well, right? This I want to show you. This was a patient that I had, right? And this was my initial 12 lead, right? So if you look here, right, what you notice, I can't really see elevations. They're subtle, right? If you look, maybe in lead 3, right? In lead 3, you could see it. But the other ones is not so clear cut, right?
You could definitely see it in, you could see it in V2.
Yeah.
V2 is clear cut as day.
Yeah. You could see it, but they're not, what I'm saying is they're not so big that like, you know, like I'm like, oh my God, there's like elevations through the roof. You could see it in the inferior leads, right? But what caught my attention here is this. You see how much the depression there is here? You see how it's depressed? Right? You see how this is depressed? The segment, right? So then I did the 15 lead EKG, right? So this is relabeled V4R. You see it says V8, V9, how it crossed out, right? And what you see here?
Elevation.
Yeah, so this person
you
has,
see it.
Correct, right? So this person has elevation in V4R, V8, and V9, right? If you look here, right, for this particular case, right, what medication you certainly want to avoid?
Nitro,
right? Nitrates. So and you know, one thing you want to be cognizant, right? Sometimes you come in, you may have a EKG that, you know, doesn't scream at you, like you have very big ST segment elevations, right? They look kind of like subtle, right? But your eye starts to catch these depressions, right? So do the 15 lead EKG, right? Do the V4R EKG. This was a call I was with Joe, and Joe like looked at me like I was crazy when I started placing leads in the back. And then we took this person to the cath lab. We saw they opened up the coronary artery, so they salvaged the myocardium, right? So be very attentive to the complaints. This turned out to be right coronary artery, and there was a posterior descending blockage. It was 100% blockage, right? So this is kind of similar, but here they didn't do the V4R. If you're gonna do the posterior wall, just do the V4R, and this should give you an indication of what's going on, right? Any questions about this EKG?
Yeah, I got a quick question.
Go
I know
ahead.
I keep asking. If you go, can you go up? Can you go down?
Yeah.
All right. The one of the EKGs that you did, right?
Yeah.
Keep going. I can't see it on my screen. The one that you did did the see right here, right? Boom. Like so, this one right here in what's that V2?
Okay.
You see some depression,
Yeah.
right?
Yeah.
And then in V2 you see an elevation. What is that? Like you see the first QRS complex. You see the depressions, and then you see right in the middle you see an elevation. What is that?
That's not an elevation. That's just patient movement, right? That's just patient movement, right? And
so that's just basically artifact.
Yeah, this is ST segment depression. This is all depression, right? This is just when you place the lead zone on the person, it's just movement. Even though you tell them not to move, there are going to be some movement of the patient. But all of this is depression, right? And how do I know it's depression? If you look at here, right, the second one, still see depressions here. So we always have serial EKGs. These are all depressions, because if I draw my T2P, remember I said it's T2P for the isoelectric, but yeah, this was just patient movement. When you put your leads on the patient, and they're in significant pain. You could tell them to stay still, but they will move.
Okay, so I was just wondering, I was like, how is it, depression, and then you see a quick elevation, then it goes back to depression.
Yeah,
Right, so
these are precordial leads. You see some movement, but you definitely see the point being here is this is the elevation, right? And then you saw elevations here, but they were not as prominent, right? They were subtle, but we still caught that here, right?
Nick, so the isoelectric line is basically you looking at it for each complex individually, right?
Yeah, and I want to
exactly for this reason.
Yeah, and I look my isoelectric line. Well, like let me put it here. I don't start looking here. What I start to do is I find my T wave, and then I find my P wave, and then I draw a line from there. I mean, sure it actually is doing. Then I draw my line like that. See what I'm doing? So I find my T to P segment, and then I do this line. So if I go here, right? So you would agree this is your T wave, this is your P wave, right? So T to P wave segment, right? I will do it like this, right? And this would be, drew it a little bit. And here, right, this is my T wave, this is my P wave. So my T to P segment for this particular one would be here. So all of them seem depressed to me. See the depressions? So this here, this V2 starts here, so this is cut off. So I'm not sure where this one is, right? But here, right, I could definitely say this is the T wave, this is the P wave, this is my isoelectric line for this, and this is all the depression. Here, this is my T wave, this is my P wave, this is still depression. But if I look here, right, let me come on the elevated side, right? So I know this is from the previous, this is my P wave, this is my T wave, so my isoelectric line should be here. So this is elevated, right? So I will do this for my complexes, and here's the same, right? So this is the T wave, I could see it, this is the P wave. If I draw my line, I could see the elevations here. So I would go for every single complex, and what you're doing is you're looking at the T to P segment to give you the isoelectric line. All right? Make sense? Okay. So we're gonna do next one over, right? Number 6. Anyone like to go? If you like to go, just raise your hands. And
I'll go again.
Okay, go ahead, James.
A 70-year-old patient with unstable angina has chest pains for 20 minutes, which was resolved with 3 nitroglycerin tablets. After performing 12-lead ECG, what is your field diagnosis? Is this patient having a STEMI? What coronary artery, if any, is involved? Okay, so let's go to, we're going to start looking from 2. Honestly, I honestly see elevation in V2.
Okay.
I see an elevation in V2. I see a depression in AVL. And honestly, it's hard to tell in 3 if that's gonna be a. It looks like a depression in 3.
Okay.
It looks like a depression in 3. And it also looks like a depression in the 6-second 2-lead.
Okay.
It looks like there's a depression. I mean, it's hard to see from my end.
So this one is a little tricky, right? These are not per se depressions. What these are T T-wave inversions, right? So this is usually indicative of ischemia. So you see on this EKG, you see T-wave inversions, and you also see something I talked about, right? They're biphasic T-waves. So what I mean by that? So if, let's say, I will find my, this is your T-wave, this is your P-wave, and if I were to draw like a line, right, my isoelectric line, here you see on this particular one, you see how it's biphasic? It goes up and below my isoelectric line, right? So up and over. For V2, you could say in V3 the same, right? So this here, this is actually a pattern specific called the Wallenstein. So let me go back to that chart that I had, right? So what this shows you is this. This is your Wallenstein. So it's deeply inverted, deep biphasic T waves in V1, V2, right? And this finding can be present for the patient who has unstable angina, and they that could occur even when they're pain-free, meaning they had unstable angina, they had chest pain, they called EMS, you come there, but now they don't have chest pain. This biphasic T wave, even though it's not a STEMI, right, it signifies there's left anterior descending artery blockage, right? So you wouldn't be able to per se activate a cath lab, but I would definitely transmit it to the telemetry and notify them that you believe they have this Wallenstein, and definitely inform the doctor at the receiving facility. Hopefully, take them to a cath lab capable hospital, right? So this is actually called the Wallenstein. This is not ST segment elevation in here, right? So it's this particular. Let me erase all this so you guys can see it, right? So this is the Wallenstein. So they say this interpretation here is Wallenstein is the syndrome found with abnormal T waves that is seen here in precordial leads V2, V3. It's associated with critical stenosis of the left anterior descending. So critical stenosis of the LAD. And that makes sense because if you remember, we said this V1, V2, V3, V4 is fed by the LAD. So that's why we see those type of changes, especially in V2 and V3. They say 75% of patients with this finding have deeply inverted T waves, and about 1/4 of these patients will display biphasic T waves in the same leads. Abnormalities are often seen in leads V1 through V4, occasionally in V5, V6. And what you need to know is patients presenting with this type of problem will have unstable angina, and they'll have critical coronary stenosis, right? Potential for acute MI. And patients with these Wallen syndromes should be transported to the cath lab capable facility, right? And they say the ECG may normalize, but you could still see this pattern when they're pain-free, right? So if you see these biphasic T waves on a person who had an unstable angina or had a complaint of chest pain, be worrisome of critical LAD stenosis. Okay, so this is just, I know this one was a little tricky. And then,
question.
Yeah, go ahead, Brian.
Is this the same as the STEMI, or is this not related?
So, and STEMI usually means you have positive troponin or CKMB creatine kinase in your bloodstream. These patients, depending if you measure the blood work, they may or may not have it. So usually, based on the literature that I have, it's basically patients with unstable angina, and as we know, patients with unstable angina don't yet have cardiac biomarkers in blood. They have chest pain that's prolonged for 20 minutes. It may resolve, but you may see this type of pattern on ECG. What this signifies is that, let's say this is your coronary artery, right? This signifies they have, and this is your vessel, they may have very significant or critical stenosis, meaning in a matter of days or weeks or maybe month, they will have a full-blown MI, right, with the involving LAD wall. So those patients should be taken to the cath lab, hopefully get the PCI intervention to put a stent on them. We place stents not when per se there's active MI. Stents also get placed when they have significant or critical stenosis. But if you see this type of pattern, right, definitely take them. And if they had a chest pain, take them to the cath lab capable, right? Inform the doctor that this is what you see. You will not be able to activate a cath lab by yourself because there's no ST segment elevation per se here.
Gotcha.
All right. So number 7.
Would you transmit this to the to telemetry?
You can, and you could tell them you believe there's a Wallens, but they will not activate the cath lab for this because there's no STEMI. So here there's no STEMI.
Okay.
Right, but this is still a worrisome EKG. That basically means this. There's a high stenosis, and I would definitely take him to a cath lab capable. I would definitely inform the doctor there, give him a copy of the EKG, say, patient had unstable angina episode, less than 20 minutes, perhaps pain resolved, but this is the EKG I got. I'm concerned that they have critical stenosis. Maybe you want to follow up with cardiology. Basically, you're not going to be like, pushing them to the cath lab table, but you advocate on the patient's behalf. Hopefully the doctor will call cardiology and they will open up the vessel. All right, number 7.
Nick, one more time. I'm sorry. Can we repeat again? So V1, V2, 3, and 4 are looking at LAD, right?
That is correct.
2, 3, and AVF are looking at right anterior.
RCA, yes.
RCA. 1 and AVL are looking at
The
RCA as well.
The circumflex.
Circumflex.
Yeah, circumflex.
And then V5 and V6 are again looking at LAD.
Yeah, they could be, and depending on the anatomy. So at this point, this could be LAD. It could also be the circumflex.
Okay. Thank you.
Yeah. All right. Number 7. We want to go, Milan?
Sure.
This one is a little tricky.
You're called to the ER to do an interfacility transfer of the patient to CCU at another hospital. You're informed by the nurse that initial troponin was normal, second troponin was abnormal, and there is no ST elevations on a 12-lead EKG. After performing your own 12-lead, what is your field diagnosis? Is the patient having a STEMI? Which coronary artery, if any, is involved? Any changes to your destination? Okay.
This is, I had a call almost exactly like this.
Okay, so there's the depression in lead 2. I'm sorry, my computer's going to die in 1 second. That's a lead 2 has a depression.
Okay. So my advice to you guys, when you start looking at, first look at the elevations. Do not look at depressions first.
Okay.
First step, find the elevations. Because that tells me the STEMI.
Okay, so V1, V2. I'm not sure about V3 because I can't figure out the isoelectric, but
okay.
I want to say yes.
Okay, so you say you believe there's elevations in V1,
V3.
V2. And
V1, V2, V3. Is that inverted on V6?
It's yeah. I could say there is T-wave inversions. Yes, T-wave inversions. So here, right, truly speaking, right, if I know it's a little bit wavy, but this is your T-wave, this is your P-wave. It's kind of hidden because the heart rate is so fast. If I was going to draw my isoelectric line, I would make it like this, right? This is my T-wave, my P-wave. So if I was drawing my isoelectric line, I will make it like this. Here, this is your T-wave. So if I was drawing my isoelectric line, I would make it like this. So truly speaking, right, your V1 through V3 don't really have elevations, ST segment elevations. You could say your V5 and V6 leads here do have some T-wave inversions, but you know where I see elevations?
AVR?
Yeah. And that leads most providers don't look at because it's not really contiguous with anything. But the problem with this is this, right? Let me show you, first of all, this is how, you see how, let me do that. I'll copy it like this. So let me go back to how AVR should look. So look, you see how AVR is here? You see the difference? Right? This is this here, this AVR is how it should normally be. Let me show you. Well, this was, you know, right? This was my patient, right? This shows you the case we're working on now, right? So here we have elevations, here there's no elevations, right? So you see the difference? And if we go to the chart that I was showing you earlier, let me make it smaller. So see here, greater than 0.5 elevations in AVR and possibly greater than or equal to 1 millimeter elevations in V1. You have left coronary artery, severe multivessel disease. So that means that the left coronary artery or multivessel disease, meaning like multiple vessels are involved, right? Could be the circumflex, the descending artery, right? Maybe even branches of the coronary artery. So they have a thrombosis and involvement. So this person, right, ST segment elevations in AVR, right, is indicative of left coronary artery or multivessel disease. So probably because of the T-wave inversions, is probably the left anterior descending, right? And why do we see this elevated is because normal cardiac impulses like from the heart is going down. But look, you see how AVR is here? So a signal of the cardiac EKG that's coming down should normally give you like an inverted shape, but it doesn't give you an inverted shape in the setting of a STEMI. In the STEMI, this is elevated, right? So this person is actually having a STEMI, right? Because they have an elevation, right? So this is still a STEMI. So the lesion, right, involved because of these T-wave inversions is probably the left coronary artery. And I would probably transmit the EKG, and my destination would probably change from the CCU to possibly going to the cath lab if that hospital has the cath lab. So if I was going to the CCU of Hospital X and they also have a cath lab, I would try to call and see, right, if I can transfer them to the cath lab. Hopefully I can send this EKG so that they see what I see, right, and I will inform them, right, look, right, this person is having a STEMI. How do we know we're having a STEMI? There's elevations. There's also now, right, elevated troponins. So second troponin was elevated. So we have positive troponins, and we definitely could say this is abnormal, right? But not too many providers look at AVR. But first, right, once you determine the underlying rhythm, right, always do the look at elevations first. You see how this is? You see how this is wavy like this? See how this is patient movement. This is just patient movement. So whenever they did the EKG, the patient was moving. That's why you have it. That's why we tell the person when we do the 12 lead, please stay still. But if they have significant pain and they're sweating, it was going to be hard to not move. So then you want to do a serial 12 leads, maybe get a better tracing, right? And also this heart rate is irregular. You see how from here to here is longer than here to here? You see that?
Yeah.
So you know what this heart rate is? What is the rhythm here, I should say? So here, this is actually atrial fibrillation. There's an atrial fibrillation. You don't really have clear-cut P waves. That's why this looks like this. So this could be atrial fibrillation, right? Which that's why you don't have really clear-cut P waves. And your rhythm is irregularly irregular. You could not do this box method. You could not do this 300, 150, 100 because they differ from complex to complex. So here you need a 6-second strip. You need to count how many of them fall in the 6 second multiplied by 10. For your irregular rhythms, you cannot do this box method because if I did the box method here and I did a box method here, I have two totally different rhythms in terms of numbers. Hopefully that makes sense to you guys. So this is AFib. How do I know this? There's no clear-cut P waves, and the rhythm is irregularly irregular. But because of this, right, it's a STEMI. All right, make sense? Any questions about this one? Okay, no questions. We got the last EKG in this packet. Anyone would like to go? If you raise your hands, you can go. Lindsay, go ahead.
All right. A 70-year-old man is presenting with chest pain after performing 12-lead ECG. What is your field diagnosis? Is this patient having a STEMI? Which coronary artery, if any, is involved? So the first thing I see, it looks like lead 3 has elevation.
Okay.
It looks like AVF has elevation.
Okay.
Not in V3, not in V2. There's depression in V1.
Yeah. And probably V2, yeah. Mm-hmm.
V6, it looks like maybe a little, not really.
So let me draw like the isoelectric line.
Yeah, that looks, that's, yeah.
Would be here. So it kind of looks right, but not really prominent, right?
Right.
Not really prominent. So I agree with you, right? But we also, we said for now, right, we have elevations in the inferior leads, right?
Mm-hmm.
Elevations. We have depressions in these leads. What type of EKG would you do next for this?
I would want to do the right side.
Yeah, right side and do the 15. They, in this case, they did not do it, right? They did not do it. Here they say it's inferior wall MI, which can result from occlusion of either right coronary artery or the left circumflex artery. And if you had ST segment elevation in at least one lateral lead, right, V5, V6, AVL, right, then it's strongly suggestive of the circumflex. So if you have either elevations in any of these leads, plus if you had any elevations here, right, on 5, V4, V5, V6, it could be the circumflex in addition to, right? Why? Because we said circumflex can also feed the inferior wall, right? Can feed the inferior wall. And if we look at the, let me go back to that diagram of the heart so you guys can see what I mean. Right? So here, this is the right coronary artery. This is the left coronary artery, right? But you see how the circumflex, I'm taking purple color. This is the circumflex and how it's coming to the back, right? So this portion still feeds the inferior wall the same way like this, right? This can feed the inferior wall, the bottom portion of the heart. You see how it's here? So depending on the person, right, you could have isolated right coronary artery just feeding the inferior wall, or you may have a lesion somewhere here where it's the circumflex. So, and how do you tell? So if you look at this diagram, right? So if you have ST segment elevations in 2-3 AVF, right? And if you have elevations in addition to it, right, in 1 and AVL, right? Or both, then you have, in addition to, you may have the circumflex involvement, right? So let me go back to that EKG. Right? This was here, right? Yeah.
Mm-hmm.
So if you have elevations in the inferior leads, and you also have, in addition to elevations anywhere here, right? Then you could have the circumflex involvement. So this person, as you said, right, Lindsay, do the 15 lead, do the right side, right? And we want to be cognizant of if it does have V4R involvement, we want to avoid nitrates. And if you also see, right, elevations in your V8, V9, you know the person is having posterior wall MI, right? something that you should definitely communicate to the doctors at the receiving facility. So this was, the 12 leads. Any questions about anything we did in terms of 12 leads so far? Or it's clear?
So you're counting lead 2 in this EKG as having elevation.
Yes.
Correct?
Correct.
Okay.
Yeah.
I didn't see it circled.
Yeah, I will show you, right? So if this was my T wave, this is my P wave, I draw my T to P wave segment like this. And here, right, I have enough. I could see it's elevated, right?
Yeah, no, I was asking because I didn't see it circled. Now I see the elevations, but I didn't see it circled, so I didn't know if you was counting it.
Sometimes, yeah, this is T and P, and it's like in some leads it's very prominently seen, right? But here, yeah, I would count this. I would count this, and this as my elevations, and I would say these are my depressions. Right?
Wouldn't AVL have a depression as well?
Yes, AVL is depressed too. Yeah, AVL is depressed, and it makes sense. That's the lateral wall, and it's the opposite wall. Yeah, and it's looking at the opposite.
Would you count AVR as a depression?
At this point, this is not a depression. This is normal morphology. It's just looking at the. Remember this one, right? Where we had elevations before, right? This is normal shape. This is normal morphology. The reason why this is normal morphology is because remember how I said normal your EKG signal travels this way. So AVR is the opposite view. So it's going to show you everything in reverse. So AVR is usually in reverse of everything. That's why the QRS and everything is pointing down. So this is fine. The only time this becomes problem is when it's elevated like that. This is normal morphology. That's fine. So when you're interpreting this, first get the underlying rhythm. Once you get the underlying rhythm, then you look for elevations first. Then you look for depressions, and depressions tell you reciprocal changes. It's basically like you are aligning it's like cementing your diagnosis, right? If you have depressions with elevations, it's like clear cut.
So like this V4, V5, V6 would show that there is blockage in the what you call it, the
circumflex.
The circumflex, yes.
Yeah.
So if that in any EKG period, like if you see that and you see something like depressions, and let's say you see depressions in 2, 3 and AVF. Let's just use that for if you see depressions, but you see elevations in V4, V5, V6, but that still state that there is an occlusion in the circumflex, or would that be something
I would say if you had depressions in 2, 3 AVF and elevations V5, V6, yeah, I would most likely say it's the circumflex. If you had an extension to elevations in V3, V4, V5, V6, I would say you also have the LAD and the circumflex involved. Yes, in that case. But if you only had V5, V6, 1 AVL with depressions in 2, 3 AVF, I would probably say it's the circumflex. Now,
but what happens if because we're looking at it from an inferior wall MI? What happens if you're having a lateral wall MI, which is ST elevations in V5 and V6?
Yeah.
And would you still be able to tell in that case that they're still having an inclusion inside of the circumflex?
So to be honest with you, James, the only way you truly know is when you take them to the cath lab and they basically go with that catheter and they push dye and they see what's what.
So we wouldn't be able to recognize.
No.
We wouldn't be able to recognize.
This here, what I'm showing you, this is basically they did trials where they, based on the EKG changes, right? When they took them to the cath lab, based on these numbers, right? Which coronary arteries were occluded. But you notice these numbers are not foolproof. It's not like 100%. They give you some sensitivity and specificity, but the only way you truly know what's what is when you take them to the cath lab and the interventionalist cardiologist goes in there with the catheter and they push dye and they can see what's closed, what's open. You could just make like a presumptive diagnosis based on this chart, which is usually correct. Like usually it's there, right? Meaning like you're not going to be like totally off, but there's variability in terms of when they actually go to the cath lab table, right? There will be variability which coronary arteries are involved. So from your standpoint, you cannot tell 100% what's what. You could have a good idea.
Thank you, sir. Thank you for explaining that to me.
Yeah, no problem. So I'll tell you what, I see we pause. Any other questions, I should say, before we can go? Any other questions before the last one?
Yeah, I just wanted to look at that last one we did. So the rate was about, it looked like 120. So would that be like a sinus tachycardia?
So let's see, right? So you said 120. So here, let's say 300, 150. Yeah, 120, 130. Correct. So we see P waves. Yeah, we definitely see P waves, and the heart rate is about 100. Yeah, this would be sinus tachycardia is correct.
Okay.
Yep, sinus tachycardia is correct. Yep. So this, I was explaining this in the lecture, right? So these were your typical symptoms, right? Where you have chest pain, all this, crushing pain. But what I was going to show you, right? This is the typical guy comes out from the restaurant. It's cold, vasoconstriction. He ate a steak dinner, right? It's digesting, and he's having this classical chest pain, left side radiation, right? But it's this one, right? The diabetics, females, the elderly, where they'll complain of fatigue, back pain, right? Dyspnea. They may have nausea and vomiting, right? And if they are insulin dependent diabetic, or even they're non-insulin dependent, right? You still want to do a total Lead ECG for those patients, because it's only going to take you a couple of minutes to do, right? And you may discover they're having MI. A lot of times I've been to like urgent cares, right? Where they call me, the person is vomiting or the person having like GI complaints. I do a total Lead ECG, and they have a full-blown MI, right? They have a STEMI, and the doctor there is in disbelief. He's like, how can that be? They are vomiting, right? Or they're having GI complaints. And I'm like, not everyone comes in with chest pain, especially these patients, right? So do the 12 lead. No one is going to fault you for doing it, but you may pick up a lot of these MIs that atypical, right? Atypical. So do the 12 lead whenever you have diabetics, you have elderly females, right? They complain of back pain, fatigue, all these symptoms. Do a 12 lead, all right?